All right, party people, we are back at it with another one. Today, we're going to be covering the dyslipidemics. Let's get it. All right, jumping right into it with statin. Statins inhibit HMG-CoA reductase. This is the rate-limiting enzyme in cholesterol synthesis. Now, I would hope that you know this by now, but if not, we're going to just instill it and remember that. On the exam, you might get questions asking for a mechanism of action, and HMG-CoA reductase inhibitor may not be there. So instead, what they want you to pick is increased LDL receptor expression on hepatocytes. By inhibiting cholesterol synthesis in the liver compensates by pulling cholesterol out of the blood. It does this by upregulating LDL receptors. This can be really annoying because for a very long time we were taught that hepatotoxicity was the most common side effect. This factoid was emphasized heavily, especially on step 1. Now, even though statins can cause myositis, rhabdomyolysis, and myopathy, it was believed that hepatotoxicity was even more common. But on newer USMLE exams, where statin is given and the answer is myopathy, where toxic hepatitis is incorrect. The term toxic hepatitis just refers to increased LFTs in general. It does not necessarily mean fulminant liver failure. Now, if you start a patient on a statin and then you see a slight elevation in their LFTs, you don't have to stop the drug or reduce the dose. Mild transaminitis is expected and totally normal. It doesn't mean that the statin should be discontinued. This is important. What's also important is the combination of statins and fibrates that increase the risk of myopathy. That's due to CYP450 interaction, and you have to know this for your exam. Now, for the ranges of LDL in relation to statin administration, you have to know that an LDL of above 190, if the patient is age 20 to 30, is called for. If the LDL level is over 100 in patients aged 40 to 75, that is also called for. Also, if the LDL is over 100 in any diabetic patient aged 20 to 75, they're getting a statin. So that is the trio. These are the cutoffs that you have to remember. Statins are not typically given to patients under the age of 20, except in rare conditions like familial hypercholesterolemia. Some guidelines will use 70 as the LDL cutoff instead of 100, but forget about all that stuff because USMLE uses 100. For your licensing exams, you have to remember 100. Now, even in the case where they give you an LDL of 95 and you're like, hey, that's pretty close, it's still below the threshold. They're not getting the statin. Remember that. Another thing that you might get caught up in is the ASCVD score and risk percentages in terms of low, moderate, high intensity statins. But for this licensing exam, that's not really covered. We can get into that in a different video. As far as fibrates go, fibrates are the best drug to lower triglycerides, especially if the triglycerides are over 300. They work by upregulating lipoprotein lipase, as well as upregulating PPAR alpha. Now, lipoprotein lipase is the enzyme deficient in hyperchylomicronemia. It helps move triglycerides from the blood into the adipose tissue. By increasing lipoprotein lipase, fibrates lower triglycerides. Now, side effects you have to know are, like statins, fibrates can cause hepatotoxicity and myopathy. Now, unique to fibrates, they can cause cholesterol gallstones, and this does show up on the exam. Also, CYP450 interactions with statins increase the risk of myopathy. Moving on to ezetimibe. Now, what they might ask is the mechanism of action of ezetimibe, and the answer you'll be looking for is decrease small bowel absorption of cholesterol. Ezetimibe does not reduce mortality, and this also goes for bile acid sequestrants. They decrease LDL, but do not decrease mortality. Unlike statins, statins reduce mortality partly due to the antioxidant effects on arterial and endothelial cells. This benefit is independent of their lipid-lowering effect. It's important to know that. Now, as far as bile acid sequestrants, such as cholestyramine, these bind bile acids and prevent reabsorption in the terminal ileum. The less bile acid returns to the liver has to make more, converting to cholesterol. Therefore, this results in bile acids, which then results in lowering cholesterol in the blood. USMLE doesn't particularly care about the mechanism. It just helps to remember this sequence and understand how this drug works. As far as orlistat, this inhibits pancreatic lipase. In turn, will cause steatorrhea, which makes sense because you're not going to be able to absorb and break down those fats, so they stay in your stool, and then you get greasy stools. As far as niacin, aka vitamin B3, it has two mechanisms. The first being it increases HDL more than any any other drug. And also, the second, it's that it decreases VLDL export from the liver. Famous side effects that you need to know are flushing, which is mitigated by aspirin. It's instigated by prostaglandin, not histamine. It can also cause gout. They might give you a question where the patient has podagra being big toe gout, and ask what is contraindicated. In that case, the answer would be niacin. Also, niacin worsens hyperglycemia, and therefore it should be avoided in diabetics. Niacin typically isn't given routinely anymore for these reasons. And what they showed in large trials was that statin plus niacin, as compared to statin alone, had no mortality benefit. So more side effects: flushing, gout, worsening diabetes. Some pre-diabetic patients would tip into diabetes, but there was no actual big term benefit, so they don't really do it that much anymore. Now, in terms of niacin deficiency, this is known as pellagra. The 3 Ds that you need to know are dementia, dermatitis, and diarrhea. So they might give you an example of Kasel necklace. This is where you have hyperpigmentation of the sun-exposed neck area. They might also just give you a forearm with hyperpigmentation. And instead of dementia, they might give you delirium. So if you have an elderly patient that all of a sudden started taking niacin, and now all of a sudden they have hallucinations, diarrhea, darkening skin, that is your niacin deficiency. Moving on to omega-3 fish oils. USMLE might give you a one-off question regarding omega-3 impact on the patient, and simply ask: the patient started taking fish oil, and what would you see in this patient? The answer for that question would be decreased triglycerides. All right, that's it for this one. Go crush it.